With that, I'm going to talk about the personal health train, which is a federated health data infrastructure that we have in the Netherlands. And I'm going to start with, I wasn't sure if this was necessary, but I think it's always good to mention disclosures. So we do work with a lot of companies in this, including medtech companies and also IT companies. I want to start with the rationale of why we're building this infrastructure, at least from the Maastricht side. And so we started with this problem. We were asking our physicians here in the clinic to predict survival. We're predicting, so they had dossiers, files of electronic hospital records of patients, and they could read through it and they could see everything that that was done before the intake, the diagnosis, and the treatment that they prescribed. And then they had to predict, will this patient be alive 2 years from now? And after reading the file, they had to put patients on a scale, right? They would say, well, this patient is quite likely to survive. Let's put them here. This patient, not so much. And when they read this, you say, no, this is very unlikely to survive. And so you classify all these patients according to a prediction of outcome, in this case, survival. And when we did this study, you can also see, of course, the truth. And when the truth is shown, you will see that they misclassify some patients and they classify correctly other patients, right? The thing about this study is that when we tested our physicians, they were actually quite bad in classifying these patients. And you can measure this by the area under the curve. So if you are very good at ordering these patients according to survival, you have an area under the curve of 1. And if you're very bad at this, your area under the curve of 0.5, and 0.72 is in the middle. You can see they classify some more patients correctly, both alive and dead, but it's not perfect. So area under the curve is a metric that we use for these kinds of things. And when we tested our physicians, the area under the curve of our physicians was 0.56. What does that mean? It means that our physicians are very bad at predicting outcomes, right? When we ask them to predict survival, basically they cannot do that. And why do we think that's a problem? Because if you can't predict the outcome of a cancer treatment in this case, how do you know which treatment is better for which patient, right? And so this is the rationale of our work, that we're trying to make these predictions better. Now, why is that people cannot predict outcomes? Well, one of the reasons is that doctors are humans, right? And humans can only take 5 things into account when they make a decision. So, obviously in cancer, but in any other medicine case, there are many more factors that go into a decision. And so humans can no longer process that. So there's an explosion of data, and that's only getting worse with more imaging and more genomics and things like that. There's more and more decisions to be taken, right? Breast cancer used to be 1 disease, now it's 8. All these have different treatments. And so doctors have to make more and more decisions as ever. We have the idea of evidence-based medicine, that on the crossroad of what you know about a patient and the decisions you might reach, that you look up literature or look up the guideline. But you can't read all the literature, right? If you want to read all the literature, you're reading about 10 hours a day. And also, much of what's in the literature is quite biased, right? There's only 3% of patients in trials, and there's very positive publication bias. And in many cases, you have a situation where technology especially is introduced, not because there's a trial, but because it's a new technology, right? So for instance, a new CT scanner for Philips is being bought by centers, not because there's evidence that it's better, but because it's the new version of the CT scanner of Philips and has sharper images. So that's the sharp knife hypothesis. And so when you look at all treatments that we give in medicine, the British Medical Journal did this analysis. They looked at 3,000 treatments and looked at, what's the evidence that we have that these treatments work. You see in about half of the cases that we have no evidence that these things work. In 1/3 of the cases, we do have evidence that they work, and in 1/6 of the cases, we know that things don't work, but we do them nonetheless. And so because in half of the cases, we miss this evidence, it's actually quite hard to do this task, to predict individual outcomes. So this was the problem that we were working on, and where we started to think about data infrastructure. Because this is where we want to go. We want to go to a situation where, rather than doing just the way we do medicine now, like clinical trials and guidelines and things like that, we wanted to use all the data that people collect every day in the hospital, use AI, machine learning, and things like that to aggregate data out of that, then use that algorithm, that prediction, that decision support, that knowledge, if you want, for the next patient, see what happens. And what we want to do is have that circle running in every hospital in the world, rather than just relying on the things we do now, which is, let's say, classical medical research. I'm going to start the chat. Give me a second. Here we go. I can't see the chat and they're asking questions. Okay. So for this, we need a lot of data, right, to work. And when you think about data, I did this calculation once about cancer, and in cancer, there are approximately, let's say nowadays, 15 million patients getting cancer every year in the world. And suppose you want to learn over this decade, 2007 to 2017, the total number of data, the data subjects, if you want, patients you can work with is 150 million. That's just, there are no more patients than that. Now, suppose you have about 100 megabytes to 10 gigs per patient. Obviously, it depends on where you are in the world, how much that is collected. The total amount of data that we have on cancer is about 15 to 1500 petabytes. Let's say 500 petabytes of data. Is that a lot of data? That is okay, right? If you think about platforms, for instance, the Azure backup is much larger than that already, and also Google has certainly 10 times as much data as this. So the size of the data is not really our concern if we think about data infrastructure. What is a little bit of a problem is that data is unstructured, right? So there's free text, there is images, but help us on the way there. Right? We speak to Siri, we have face recognition, deep learning, and so there's things that work. What is the issue in medicine is that there are so many hospitals, right? If you think about this 500 petabytes of data is spread around approximately 100,000 hospitals in the world, right? So that 150 million patients is spread around 100,000 pockets. And getting access to those pockets is what's difficult, right? So for us, the problem in medicine in terms of big data and data infrastructure is not the size, it's not the fact that it's unstructured, it's the fact that it's so dispersed, right? And you can't get access to it. So why can't you get access to it, right? If I go to Toronto and ask, give me all the data of the Princess Margaret Cancer Center, I get a few answers, right? The first answer I get is, well, Andre, I don't have time to fill in your Excel sheet, right? Or to capture all that data. I don't have the time, you have to pay me or, have to bring money. I don't have the resources. The next thing they say is, well, I don't want you to have my data because, we have in UHN lots of PhD students ourselves and we want to publish on our own data. Or, if maybe you're finding that we're doing something wrong and then patients will go to Sunnybrook or, there are many reasons why people don't want to share data. It's a political argument. Then there's the ethical argument. I'm not allowed to share data. And of course, in Europe with GDPR, we have now this, everyone's using this left and right. When people say I'm not allowed to share data, what they really mean is that they don't want to or they don't have the resources, right? Because in every legal system in Europe and in Canada as well, it is perfectly possible to share data with each other. But it takes resources, right? You may need to ask patients' consent, you may need to de-identify the data, and it takes will, but it's not impossible. Technically, there's certainly not an issue, right? We stream Netflix movies. That's not an issue at all, to be honest. The technical aspects, they can be solved, to be understood. So how do we then now share data, right? If it's so difficult, how do people share data at all, you might wonder? Well, there are three options we feel. So one is you have clinical research, right? Clinical research, what you do there is you ask for money from the government or from a charity, and what you're doing there is basically asking for money, and what you're doing is in 3% of the patients collecting a lot of data elements with very high quality, right? So very little missing data elements, but it's only 3% of the patients. The next option you might have is registries, right? Registries are situations where on a national level or on a regional level, you collect data on all patients, but because it's so much work, you only collect maybe 3% of the data. And also the data that you do share is not so high quality, right? So there's more missing data. Those things are interesting, but we're really interested in the routine data, right? Because the clinical routine, so just the data that we record every day, has all the data elements and all the patients. but it's very low in quality. But still, if you calculate all the green dots in the middle here, you have 10 times as much data points than sit on the sides. So we're really keen on, of course, getting our hands on the sides, but more keen to get our hands on the middle. So we were asking ourselves, how can we get access to all the data of all the hospitals in the world? That's the task that we're setting ourselves with data infrastructure. Now, very quickly, you then come to the realization, right? If not all the world wants to send all the data that they have to Maastricht here in the Netherlands, so that we can ask the question that we want to be asked to the data. For instance, make a prediction model that can determine which treatment works best in lung cancer, right? If not everyone sends the data to Maastricht to answer our questions, then we have to send the questions to them, right? And so that's if you can't bring all the data to the research, you have to bring the research to the data, right? That's what we're realizing. Now, in the beginning, it meant a lot of traveling. An introduction already. There's talk. I spent lots of time at different universities, including in Canada, to analyze data there. But of course, that doesn't really scale well. So we needed an infrastructure for that. And the infrastructure has the metaphor of what's called the personal health train. And so the first thing you have to think about, okay, I have to package my research question into an application and send it to Shanghai, for instance, right? And that application can be, for instance, a machine learning algorithm that again learns some kind of prediction model, which is our typical use case. We call this trains, right? An application that you send, and nowadays you use things like Docker. But of course, if Shanghai then receives our application and then starts running inside their hospital and accessing data and communicating with the outside world, Shanghai has to have a lot of certainty that this is not a virus and that it works well. So you need what's called trap, right? That has the audit and the checks and the security. That's still not enough, because if I send a train from the Netherlands to Shanghai, that train doesn't speak Chinese, right? And so for this to work, Shanghai has to put their data into a state where an application, so no longer human, an application can not only read the data, but can understand the data. And that's nowadays called fair data. So that's called fair data stations. And you see here the metaphor of the personal health train coming with tracks, trains, and fair data stations. We do this on a global scale. And for different use cases and even different diseases nowadays. And we made a small animation on that to explain the principle a bit further, which I should be able to start in a sec. Get rid of my pointer. Here we go.
The personal health train's main goal is connecting health data to make them more usable. Personal health management requires increasing amounts of personal data, but today this information cannot easily be used because the data are produced and managed by various healthcare providers, authorities, and more by citizens themselves. These stakeholders collect and manage their data in different ways, making the data hard to find and use. Furthermore, personal medical information is very privacy sensitive. As a consequence, personal health data cannot be used easily by citizens themselves, by physicians, and by researchers. The personal health train goes to the root of this problem by building fair data stations. Fair protocols ensure that data are findable, accessible, interoperable, and reusable. These data stations are connected by tracks, which are strictly secured and protected. Fair data trains are constantly monitored, and only trains with the appropriate validation may enter a particular station. To secure privacy, every data station has rules. Each data owner has access to his or her secured station and can easily request and control one's personal information. In addition, the owner can set rules for who can access the data and how it may be used. Communities with common interests, like patient societies, can choose to connect and organize their information through umbrella stations. With this access, a researcher can learn, for example, which cancer patients benefit most from novel therapies such as proton therapy. or a citizen with a specific variant in his genome can be automatically alerted when new research results, insights, or possible risks become available. In this approach, the information is accessible for research, prevention, and education without the data ever leaving the station. With the personal health train, health data
that's the idea, that health data becomes available without people losing control. And that's what we're setting up in the Netherlands. So I'll give some examples of the work that we do using this infrastructure, also to get you some inspiration, I guess, for the DHDP on what is possible. So one of the studies, the earliest studies that we did was in our region, right? So we're in the south of the Netherlands, which is very close to Belgium and Germany. And so we did this study where we're trying to learn, again, predicting survival of lung cancer patients. And what you see here is a hospital in Belgium, in Hasselt, a Dutch-speaking hospital. And they have some alive patients, the red, and some diseased patients, the black. And so when Hasselt wants to learn a model, Hasselt would probably say, well, the model has to look like this blue line, right? That separates the alive from the diseased patients. And so that's a good model, right? For us, at least, to separate the patients. But if you ask, the same question to Liège, which is French-speaking Belgium, they say, well, no, it should be the green line. And why is the green line different from the blue? Is because Liège has different patients in their hospital, right? Maastricht might say totally different. It should be, this purple line. Eindhoven, a red, and Aachen in Germany might say the orange. What's important to understand now in this whole concept is that we don't share the individual data points with each other. We share these lines with this platform, the personal health platform. And these lines are, by definition, non-identifying, they're privacy preserving. And what you can do is you have these different lines, and now you can reach consensus. This is an iterative process that requires some math, but then you can reach a consensus, in this case, the black line, which is the globally optimal, at least in our region, the regional optimal prediction model to separate the alive from diseased patient, right? And so this is what you can do in terms for predictions. And this model already had an error in the curve of 0.77. If you remember, the physicians are at 0.56 for this exact same question. This is 2-year survival in non-small cell lung cancer. A question that we often get is such a distributed or federated learned model not worse than centrally, putting all the data into one place? The answer is no. There is no difference if you iterate long enough. That's on the right. And this holds for basically all the machine learning models that we have looked at, including deep learning. You can perfectly well federate that without losing any signal quality. If you look back, this is a few hundred patients. Now in the 20K challenge, we're scaling up to 37,000 patients on a more global scale. This is what we did about 2 years ago, where we show that 100 patients are not so impressive, but 37,000 patients globally, that's impressive stuff. And you're able to learn such things on a much larger scale now. Another application that we're looking at is slightly different, but we use the same technology. And this is where health insurance companies and the government suddenly became interesting. What you see on the left, and this is in Dutch because that's how the report is. On the left, you see every dot is a hospital, and our hospital is the red dot. And so there are 20, I think, hospitals in this country that do this treatment. And what we're comparing here is quality, right? So this is the number of patients, non-small cell lung cancer patients, that were treated with concurrent chemoradiation. Right? So in principle, this should be 100% because the guideline says 100%. But you see some centers that almost none give none of their patients concurrent chemo, like this one. And then there are centers like this one that almost reached 100%, right? So this is a quality indicator for the government and health insurance companies. They might say, well, if you don't treat the guideline treatment, then we might not contract you for giving that treatment. Now, if you look at this, this is kind of a semi-private, right? Because every hospital is a dot. And for instance, we all know that this is the hospital in Rotterdam, Erasmus. Why? Because it's the biggest hospital in the country. So, and they have the most patients. So what we're trying to do now is using this with the personal health technology to learn basically to determine those quality indicators locally so that you have a way to calculate this quality without sharing your hospital data. Until now, and I'll talked about things like which are called horizontal partitions. This means that there's a hospital in Maastricht that has data, for instance, Shanghai, where we assume that we both have the complete data elements. But really, and this is a Canadian slide, if you think about the data that you need, it's probably also outside the hospital with patients themselves or socioeconomic data that we want to have. And that's a vertical partition, right? So in this case, for instance, you have some data in the hospital, in our university medical center, and some data as statistics are now, for instance, the income of patients, and this might be diabetes. And now you want to combine those two together. This is a difficult use case. Vertical partitions, I won't go into all the details there, but there is a way to do this with secure multi-party computation and lots of encryption to do a similar analysis as in the horizontal partitions where you can learn from each other's data without sharing any private data. I want to end with community building, right? In a DHDP, this will be important as well, and it was important for us. So in the personal health range, this is really a quadruple helix, as we call it. It has governments in there, it has patients and citizens in there, it has scientists in there, knowledge institutes, and of course, healthcare people and industry. And only by creating that community, and here you see, all these people starting, the train leaves the platform. This was very important for us to gain relevance, and you can see things like the personal health trainer coming back in these kinds of animations that in our case the health ministry makes, and so that shows that building that community really has helped us build a national infrastructure, and that will continue without us, right? Without us and us academics, because it's important, of course, to give, if you want, these ideas to other people, to industry and non-academics, to really have a good infrastructure that is also serviceable. The next step in our country is to do this cross-sectoral. If you think about the situation where you have sensitive data and stations that you want to learn from, this is in hospitals and medicine interesting, but of course, other people also put their hand up, like farms, for instance, right? They don't want to share data between each other, but they want to learn from each other data without, disclosing their data, for instance, to Bayer or Monsanto. Bankruptcy curse, human trafficking, gender diversity, pay difference, right? Can you have a train visiting all kinds of companies that determines the pay difference between the CEO and the lowest paid worker, so that we have this more social, responsible industry. And so you see this suddenly being used cross-sectorally, which is a good thing, because then lots of the technology can be even more mature and more supported than just in healthcare. We did an analysis of different options. The personal health train is here. That's a sector-specific one, but a generic data infrastructure with AI capabilities is being set up in Europe, amongst others. It's called International Data Spaces. And that has the same concept as the personal health train. So everyone gets, it's not called no longer a station, but now a data space, right? With all the things that you want here, and they're under there, authentication, authorization, all the trails, encryption services, all that stuff, so that you have a generic infrastructure to share data with each other, which is also, again, good for medicine, because if, for instance, we have data from socioeconomic, like income and education, this is actually quite important for prevention use cases, for instance, right? So we're also, by making this a cross-sectoral industry, we actually can ask questions from the health side and from the medicine side, which we weren't able to ask before that. So we think that's important to include other industries, and that is what's happening now. With that, I hopefully give you some inspiration about the way we view a DHDP-like system, right, in the country. To summarize, we really believe that you should. There's a place and time for centralized data. Let's also agree on that. But we feel it's much more important to focus on federated data infrastructures, where instead of putting all the data in one place and having people access to subject level data, we share questions with each other, which are then answered on different spaces or different data stations, and the answers combined rather than the data. From a European side and a Dutch side, that's much better for privacy, but also it allows you to start auditing the questions, right? And ask yourself, is this really a question that we want answered using data, right? And that's more a social and ethical question, which is good to have. With that, I'll stop here and give the word back to Francois for some Q&A.